Good evening and welcome. I'm James Liu and I'm a librarian at Stanford Health Library. Thank you for joining us. Our talk tonight is entitled The Basics of Kidney Health. It's my pleasure to introduce our speaker, Dr. Brian Brady. Dr. Brady is a fellowship-trained nephrologist with broad certification in nephrology and in internal medicine. He's a clinical assistant professor in the Department of Medicine, Division of Nephrology at the Stanford University School of Medicine. Dr. Brady is particularly interested in the management of patients with chronic kidney disease. He also treats end-stage kidney disease, hypertension, kidney stones, glomerular disease, and other kidney-related conditions. His research in value-based healthcare focuses on methods to improve healthcare delivery for patients with chronic kidney disease and end-stage kidney disease. He has received funding for his research from sources including the National Institute of Health. Dr. Brady has published his research findings in JAMA, Internal Medicine, the Journal of the American Society of Nephrology, and elsewhere. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen. At the end of the talk, Dr. Brady will answer as many of those as well as the pre-submitted questions as possible. Dr. Brady, I'll turn it over to you.
Thanks very much, James. Let me pull up my slides here. Good evening, everyone. Thanks for taking some time out of your evening to join us. James, thanks for the introduction. Very, very kind and generous introduction. You must have heard me when I said family might be joining tonight's talk. Anyway, it's a pleasure to join everybody. I've been tasked with convincing you that the kidney is perhaps after the brain, the most brilliant organ that we have in the body, and I've only been given about 35 or 40 minutes to do it, so I will get started right away. Some objectives for tonight's talk, just to keep us focused. First, I hope that I can help folks understand how your kidneys keep you feeling well. And we will review the most common risk factors for developing kidney disease. We'll discuss some of the health risks associated with kidney disease, try and understand the treatment strategy for folks with chronic kidney disease, and discuss the opportunities for disease prevention and slowing, hopefully focusing mostly on the last two, because in the last 3 to 5 years, there's been an absolute explosion in the number of therapies available to help patients with chronic kidney disease. It's really energized our field. So first, it's hard to go to a nephrology talk without seeing a little bit of anatomy because we all love physiology so deeply. I think everybody knows where their kidneys sit in the body, but for diagram purposes, they sit in your lower back. They create the urine at the top of the stream, so to speak, that then flows down through your ureters, is held by the bladder, which is just a smart muscle that contains the urine until you're ready to excrete it and void, and then it comes out. I joke with our urology colleagues that once the kidneys produce the urine, everything south of the kidneys is a plumbing problem. On the right-hand panel, you can see if you actually break the kidneys down, what you have microscopically on each side, each kidney is composed of about 1 million of these individual kidney filtering units called nephron. You can see here, these are electron micrographs, which is just a very high power microscopy picture of all the blood vessels that are intertwined here in what is called the glomerulus, which is where the blood goes into and is filtered ultimately for the kidney to decide what is waste and needs to be avoided and what is good and needs to be held on to. At the end of the day, even though the kidney does many things, its perhaps most unique feature is that it's the body's primary filter, in addition to the liver, but in a different way. Down here, you see a picture, cartoon of the nephron, which I wanted to devote about a minute to just to work on my task of convincing you of the kidney's dominance in the body as far as organs go. So on each side, you have 1,000,000 of these individual filtering units called the nephron. If you imagine the blood filters in through the left and is dealt with in this filter here called the glomerulus, good things that your body needs to hold on to continue to pass through the blood and cycle through the whole body again until we come back to the filter. Things that the kidney considered waste get pushed into this tube here, which essentially is where the urine starts. These again are microscopic. So you have, hundreds of thousands to 1,000,000 of these, depending on your age, producing urine as they filter the blood 24 hours a day, 7 days a week. And as the urine passes through these loops and different parts of the tubule, all of these numbered areas are different points along the way where the kidney makes a decision: do I need to keep this or do I need to waste this? And this is where all the electrolyte handling happens. Do I need more sodium? Do I need more water? Do I have too much potassium? All those decisions are made by the kidney as the urine is passing through here constantly. And eventually, the product that comes out of the end of the nephron, the collecting tubule, that's the urine that passes then into the ureter and the bladder. So in that vein, what do the kidneys do? We all, I think, know that their primary responsibility is to filter the blood. In medicine, or I should say in the business, most of us talk about this being called clearance. They are clearing molecules that you don't need. And commensurately, as the kidney function declines in folks with chronic kidney disease, the clearance becomes less and less. Thankfully, you're born with so much more kidney function than you need. Most people, even if they have chronic kidney disease over the years and lose kidney function and lose clearance capability, they will never feel any ill effects of the accumulated so-called toxins in what most people kind of refer to as toxins, which is all the waste that the kidneys are supposed to get rid of. That's primary function, but you'll see that there are actually 5. And this is, again, part of my argument about the brilliance of the kidney. The second thing they do, which I think most people are aware of, is balance all the electrolytes and also maintain acid-base balance. So we're all, I think, familiar with the term pH. If the body's pH isn't kept within a very kind of narrow range, different organs begin not to work. Enzymes within organs don't work. And so the kidneys are responsible, along with the lungs, they work in concert with the lungs, to make sure that the body has not too much acid and not too much base, too little acid, too little base. And all of those points along the nephron is where those kinds of things are dealt with. Additionally, they balance electrolytes. So they're primarily responsible for potassium handling, calcium handling, magnesium handling, all those electrolytes that we know about that you might take supplements with. The kidney's job is to say, did I just have a very high sodium meal? Did I have a great burger in and out tonight? Do I need to get rid of sodium? That's where that decision is made at the level of the kidney. They also are responsible in a similar way for maintaining water balance. So most people don't think of it this way, but there are certainly times when we have an excess amount of water, and there are times when we have a deficient amount of water, which most people are more familiar with. That would be dehydration. But this is evident when you look at the color of your urine. If your body is deficient in water, like if you've been hiking for a couple hours and only have a liter of water to drink, body's trying to conserve water, your urine will be very concentrated, will be very dark. If, on the other hand, you are very well hydrated and you just keep drinking water for whatever reason, your body will say, I don't need more water. I'm going to filter all this water out through the nephron and into the urine. Your urine will be very clear. So what we'll get to later in the talk is lots of patients will show up and say, well, how much do I need to drink? It really comes down to just making sure that the color of your urine is relatively clear. If it's relatively light yellow or clear, then we know that the body has enough water and it's getting rid of some of the excess. The kidneys contribute significantly to bone health. We won't get into a lot of this because it's outside of the scope of tonight's talk, but in the calcium, phosphorus, vitamin D axis, the kidney is in part responsible for helping convert inactive vitamin D to active vitamin D. Additionally, it controls calcium homeostasis, phosphorus homeostasis. And so folks who have more advanced levels of chronic kidney disease, if we don't manage them appropriately or they're not picked up early enough, can run into problems with osteoporosis and early fractures and this kind of thing. Lastly, they produce a key hormone responsible for producing red blood cells. So many of you, I'm sure, are aware, patients with more advanced stages of chronic kidney disease become anemic. And so as their kidney disease progresses, one of our treatments for them is to replace this hormone as another one of their facets of the medical treatment regimen. This hormone is called erythropoietin and is given to patients in the form of an injection or a monthly or biweekly shot. This is an important slide. It seems self-explanatory. It may be for many on the call, but for those who have not heard this term or may think they have kidney disease and not heard this term, it's very important because kidney disease over the years has been tagged by many different names, some including failure. Some will say renal failure, some will say kidney failure, some will say kidney impairment, some will say, the doctor might say, I'm watching your kidney function. The terminology that we have been using since the early 2000s, actually at a conference about this, believe it or not, in Cornell in like 2008 and 9, is chronic kidney disease. And there are stages of chronic kidney disease, which we will get to. But the term that is most appropriate is chronic kidney disease. But you could imagine it doesn't sound very nice. And so many times when I meet patients in the office, me using the term chronic kidney disease or CKD to them is the first time they've heard this. And it takes a little bit of explaining to let them know that this very scary sounding phrase actually just speaks to what is actually going on. So that's why I devoted an entire slide to that. In broad strokes, what causes chronic kidney disease? Again, diagrams not to scale, as I know at the bottom, but the two major drivers, both in the US and worldwide actually, are diabetes and hypertension. These account for the majority of the cases of chronic kidney disease. There are lots of other causes. I picked a few to put in these smaller categories for the purposes of tonight's talk. Heart disease runs many times with kidney disease, so coronary artery disease, heart failure, arrhythmias such as atrial fibrillation, atrial flutter. These oftentimes can be linked to causing or worsening folks' chronic kidney disease. And then there's lots of other things. I just chose a few. So bad infection, pneumonia that puts you in the hospital, certain medications, and then very rarely, there are a handful of inflammatory diseases that cause very kind of aggressive forms of primary kidney disease. The distinction is important because, the kidneys are just kind of sitting there all day long, quietly doing their thing, filtering the blood, keeping you in balance. Most chronic kidney disease is not because the kidneys are ill or diseased, within the kidney themselves. Most chronic kidney disease is the result of chronic illness outside of the kidneys, i.e. systemic disease, inflicting years of damage on those tiny kidney filters. That's how diabetes and hypertension cause chronic kidney disease, which I think we'll get to in the next slide or two. Now, so how does type 2 diabetes and hypertension harm the kidneys? So if you remember back to the tiny microscopic filters, the glomerulus that I showed you on the second slide, you remember that little tuft of blood cells, very delicate looking. This is the individual functional unit that you have a million of on each side. If you imagine at the microscopic level, those glomeruli are just like filters. They are filters, but imagine them being like your window screen filter you take out in the springtime to clean. And the blood pressure is the blood flowing into that filter that then gets processed. If your blood pressure is higher than average, you're exposing those microscopic filters to higher pressure than they were built to withstand. And so it kind of makes sense that over time, years and years of pressure that is just too high, it's like spraying a hose on your screen, cleaning your screen in the springtime, that you have it, 120%. Eventually, if you spray it on that screen long enough, it's going to cause damage to the tiny holes and slits within that window screen. imagine your kidney filter behaving the same way. Diabetes is not a pressure-related problem, so to speak, but more, the way I explain it to patients is, if you imagine your blood cells are running around, your hemoglobin is running around with extra sugar molecules, glucose molecules that are glommed onto it, stuck onto it. They're passing through the filter and they're causing the filter to just get blocked. They're more, for lack of a better word, they're more sticky. They cause the holes to become plugged up. Just like when you take your window out and some of the holes have dirt. Imagine that as the analogy to what happened to diabetes. And then over time, as more holes kind of fill up, you're forcing the same amount of blood volume through fewer filter holes. And so now you're back to the pressure problem, like we talked about with hypertension. Those holes will eventually widen and the filter becomes incompetent. And that's how the harm is done at the glomerular level, the filter level of the kidney. Eventually, if this happens long enough, the filter becomes scarred. And once the filter becomes scarred, it's just like if you cut your hand, the scar tissue is kind of fibrous, and it's not something that you can go back and reverse. Which will be a key theme with all of the talk tonight, is that chronic kidney disease is a disease of prevention. Once the damage has happened, once that scar has developed or propagated, we don't have a way currently to undo damage that's been done at this microscopic level. So how do we measure kidney function? This is a little bit of a joke, but not really, because for better or worse, chronic kidney disease is mostly asymptomatic until the very, very late stages. And unfortunately, if you're not getting regular care, perhaps you're not getting labs regularly, you as a patient may not feel anything that is happening differently, even if your kidney function is progressing, before your eyes, so to speak. And so getting regular labs, while it is very simple, is the way that we as internists, nephrologists, cardiologists, endocrinologists, whomever, keeps track of how your kidneys are handling filtering your blood, how they're performing, how they're functioning. So labs are the key. Part of the reason I think most nephrologists go into nephrology is they like something that is objective. Labs are objective. And so we can just look back historically when I meet patients in the office, and I can see exactly how the kidney function has changed over time if I have lab data available to me. There's two ways that we look at kidney function in how we evaluate a patient's kidney function by labs. The first is a blood test called serum creatinine, which probably many of you have seen or looked at in your lab reports. This is abbreviated CR, CREA, CREAT. It is a number that's usually around 1, although in patients with moderate or advanced chronic kidney disease can be 2 or 3 or 4. This creatinine concentration corresponds to what is more important, and that's called the eGFR, or the estimated glomerular filtration rate, which is just how much blood the kidneys are processing per minute. A GFR is actually the more important number because, as you'll see in the next slide, it helps connote what category or what stage of chronic kidney disease each person is in. So the creatinine is what we measure in the blood. The eGFR is a calculated number that comes from the creatinine. As the creatinine goes up with worsening kidney function, the equation is such that the eGFR goes down. So I always tell my patients, you want your creatinine to be like your golf game, as low a score as possible. And you want your eGFR to be like every other sport with as high a score as possible. In addition to blood, most people get regular routine blood tests from their primary care doctor. The creatinine and eGFR are very commonly reported. Even if you're not seeing a nephrologist, they're part of the standard annual metabolic panel that most primary care doctors or cardiologists, whomever, will get. But what fewer people than should, I think, get are urine studies. And the urine, arguably, is as or more important to us, anybody thinking about treating a chronic kidney disease, because the urine tells us what the filter is doing. So remember back to that nephron diagram, the tuft glomerulus at the beginning, with the urine passing through the tubes and coming out. And then think back to that microscopic picture with all the delicate vessels. The urine tells us if the filter is working or not. So if we start to see things in the urine that are good, it tells us the filter is not working correctly. Remember back to what the kidney does first and foremost, it's clearance. So the kidneys are supposed to hold on to good things like blood, red blood cells, protein, albumin. Albumin is just the most predominant protein in the urine. And usually if the filter is working well, those molecules are too big to pass from the blood into the urine, and so we don't see them. But as we see more protein develop, more red blood cells pass into the urine, it tells us a lot about how the kidney filter is functioning. And what is really important is that once the serum creatinine concentration begins to rise, it's very difficult for us to go back and make it better. And many patients will come in and they will ask, how can I make my creatinine better? I wish I had a way, but we don't. Once the creatinine has risen for a long enough period of time, we think of the damage as being chronic or permanent. However, on the other side, if we see protein develop in the urine, that is an earlier marker of kidney injury or kidney disease than is the blood tests. So protein and albumin in the urine gives us a heads up that something is going on. It's a harbinger for what may be coming. And it allows us to focus our treatment much more specifically than if we just have the blood tests. So if you're, a patient out there and you're wondering, do I have kidney disease? Have I been told I have kidney disease? Understanding your labs is key so that you can be engaged with your doctor, with your providers in how you can treat it. And having urine studies, general about every once a year or maybe even every 6 months is part of that equation. So what's the risk of having chronic kidney disease? As I mentioned, most stages or phases of chronic kidney disease are asymptomatic. So you can see on the left blue panel here, you have stages G1 to G5. G1 is normal. I'm not even sure why they have G1 because it's normal functioning kidneys. Stage 2 or G2 is mildly decreased. These numbers here in this middle column correspond to the eGFR, and that's why I was saying eGFR is more important to me than creatinine because it tells me where patients fall along the spectrum. And this chart, if anything, should show you that not all kidney disease, chronic kidney disease, is created equal. The chart colors on the right panel here denote risk. Risk of what? Risk of progression. So while you may not experience symptoms in the early phases, what we all worry about are the folks who are going to progress through their kidney function to the later phases where they might need dialysis or a kidney transplant. And everything we as nephrologists focus on is trying to mitigate that risk, slow down the progression, and forestall dialysis or transplant as long as we can. And so on this particular chart, this is from the National Kidney Foundation, you can just Google it, it's a CKD heat map. Green is low risk of progression, the lighter yellow is a little bit higher risk, orange is a little bit higher, and red is the highest risk of progression. And so I show this because I want to convey to you how important it is to know what's in your urine. You can see that for folks at the upper end of the GFR spectrum, so this would be me, I'll say, any young person with normal functioning kidneys. Of course, if they have very low albumin, they're going to be in the low risk category. But if they have high levels of albumin approaching the urine, you can see that even somebody with normal GFR can be at higher risk of losing their kidney function. And you can see for most people in their 70s, 80s, developing stage 3A or G3A disease is not uncommon. Certainly doesn't mean you're going to progress to the later stages. But you can see that if your GFR is in the 50s, you have albuminuria, all of a sudden it becomes a much more significant diagnosis. And that's, I show this chart so that folks can understand how we use both the blood tests and the urine test to understand risk. So what if I won't need dialysis, which most people won't? You'll see from the numbers that many patients have chronic kidney disease. but the majority of them will not need dialysis. So CKD is asymptomatic until its advanced stages, as I mentioned. The potential for reversibility and slowing disease progression is highest in the early stages. So we want to see patients early on. We want to see patients when we have a chance to intervene and use medicines to actually affect the course of disease and preserve folks' kidney function for as long as we can. The primary risk for what is called non-dialysis requiring chronic kidney disease, i.e. chronic kidney disease that is not yet on dialysis or progressed to the advanced stages. The primary risk to those patients is cardiovascular disease. And we'll see in an upcoming slide how powerful that risk is. I say that because anybody on this call who might be worried about chronic kidney disease, it is not just about worrying about the progression, it's about making sure that your cardiovascular risk is evaluated in the light that it should be, which is in a more scrutinized way for patients with chronic kidney disease because of the risk of heart disease so much higher. So this is a very famous paper that came out in 2004, believe it or not, only about 20 years ago. It was done in Northern California between UCSF and Kaiser, and Alan Go is a nephrologist at Kaiser. Glenn Churtel, my primary mentor, actually used to be at UCSF, now is at Stanford. And this wasn't known, believe it or not, but now it's just common knowledge. If you look at the panel on the left, this is the risk of 3 different events as the GFR gets worse. So as you move from left to right, these are people with better kidney function on the left. These are people with more advanced CKD on the right. And you can see that the first panel up here is age standardized rate of death. Second panel is risk of cardiovascular event. The third panel is risk of hospitalization. And you can just see that it's a logarithmic scale. The risk of all 3 of these things goes up logarithmically as the kidney function gets worse. And believe it or not, this was not known, but now it is known, but I don't think it's trumpeted enough outside of the nephrology realm, cardiology realm. Patients with stage 3 or 4 chronic kidney disease have 11 and 22 times higher risk of cardiovascular event than folks with without chronic kidney disease. I mean, the numbers are staggering. If you look at the table from the study, you get a sense. These are hazard ratios. So hazard ratio of 2 would be double the risk, 3 would be triple the risk, etc. And you can see that as the kidney function declines, the hazard ratio goes up, again, logarithmically from any cause death, any cause cardiovascular event. I show this not specifically to show you the numbers, but to show you the image and drive home that even if you're not going to need dialysis, if you have chronic kidney disease, your risk of cardiovascular event is much, much higher. This is a more recent paper from 2015, and what this is looking at is not just GFR, but albumin levels in the urine. And so down here, you can see the panels on the right side look at albumin, panels on the left side, again, look at eGFR, and then this is cardiovascular mortality in the top panel, heart disease, stroke, and heart failure. So here, if we this is a better slide to focus on what happens when the albumin goes up. Again, this is protein in the urine. So increasing protein in the urine drives up heart failure events. Increasing protein in the urine drives up stroke. Increasing protein in the urine drives up heart disease and cardiovascular mortality, cardiovascular death. So most of us think that the primary driver of the data you saw on the prior slide is not just the GFR, but that the albumin area actually carries the stronger risk for all these bad outcomes. And that's why checking the urine and understanding how much protein you have in the urine is so important. A couple slides on just demographics, how we're doing in the US kidney disease by the numbers. So the USRDS is the primary epidemiological kidney data collecting system that we have in the US, and they run a report every year. The most recent is 2023, but the data are only so they're not from 2023. Obviously, they're usually a year or 2 behind. I think 2021 data is what we see here in the 2023 report. can see this is just looking at prevalence. So that's how many people per population, or what's the percentage in a population that have any type of disease. So stage 3 disease, you can see here, stage 4 CKD here, stage 5 CKD here. And this just gives you a time, 2005 to 8 in blue, 9 to 12 in red. You can just see the time kind of increasing as you go across the bar graphs here. So as I say, most of chronic kidney disease is in the earlier stages, stage 3. And then you can see it drops off significantly for the folks with stage 4 and stage 5 disease. But unfortunately, I don't have a slide of this, but if you look at when patients are referred to see nephrologists, the graphs unfortunately don't look quite as dramatic, because too many patients are referred later on when the opportunity for intervention unfortunately is less. This is incidence of ESRD, or end-stage renal disease. Incidence is the annual number of people who develop any type of disease. So prevalence is percent of a population, everyone on dialysis, everyone with ESRD in the population. Incidence is how many people started dialysis that year. So you can see the incidence of ESRD continues to go up. Although if you look at prevalence, the graph is even downward sloping because of the growth of the population. This just means more people over time are developing end-stage renal disease. Again, prevalence, you can see what's interesting is that starting in 2019, the curve flattens out. And there are a lot of reasons why people think that is, but you can see that's the first time in 20 years that the prevalence of ESRD within the population starts to relatively come down or flatten out. Adjusted prevalence of ESRD by patient characteristic. This is a really important slide that I like to show because unfortunately CKD, kidney disease, discriminates against folks from disadvantaged backgrounds, or folks who may not be of different socioeconomic classes. So you can see, if you look at prevalence of end-stage renal disease across the white, Black, Hispanic, Asian, Native American populations, you see that Black patients have a much higher prevalence than the rest of the ethnic groups here. Hispanic, Asian, Native American have higher prevalence in the Black population. And this is kind of a talk in and of itself, but I thought that I should show you, at least when you break down the prevalence, unfortunately, there are significant disparities across different ethnic groups. So how are we doing in our country when it comes to end-stage kidney disease? This is a graph that looks at annual incidence. So again, how many people are starting per year across many different countries across the globe. The US is second only to the tiny country of Taiwan, which has the highest prevalence or per capita rate of end-stage renal disease in the world. So all the resources and heft in the US, I would argue, I think we could probably be doing better. I know I have to be mindful of time. I just show this not to go through every single historical point. This is just an interesting aside for any lovers of history on the call. As you may know, folks who develop kidney end-stage renal disease are the only patients, only people in the US, apart from those patients who have Lou Gehrig's disease or ALS, who can become eligible for Medicare early, without being disabled, without being over 65. And this is very unique and important because it has made dialysis and kidney disease a primary focus of policymakers and legislators for many, many years because of the cost. So it's actually written into law in 1972. It was 2 sentences in a very large bill that got passed, at the 11th hour. Any patient who developed end-stage renal disease could become Medicare eligible. The idea was that dialysis would be used as a bridge to kidney transplant, but because of the the imbalance in the number of patients developing ESRD and the availability of kidney transplants, there are many, many more patients now on dialysis than there are who get a kidney transplant every year. And so what was a modest government program at the beginning now has a budget of about $50 billion a year, which is more than the NIH spends on funding all of the medical research it funds annually. And so this ESRD program is a big deal to folks on Capitol Hill, policymakers, people who think about, like me, people who research healthcare costs. I just thought I'd put that in there as an interesting aside. So how do we treat CKD? Importantly, chronic kidney disease is managed, it's not cured. Unlike an infection that I could give you an antibiotic for, what we focus on is slowing disease progression and managing its complications. Because as I said, once that scar tissue develops in the glomerulus at the filter level, the damage is irreversible. And so we focus on minimizing future damage and mitigating any risks which might cause that future damage. Most treatments for chronic kidney disease are not specific to the kidney. They, again, getting back to the kidney being kind of an innocent bystander, it's treating the underlying disease that might be making the kidney function worse, i.e., your diabetes is out of control, getting blood sugars under control. Your blood pressure is out of control, getting blood pressure under control. These are the primary strategies for managing chronic kidney disease. It's aggressive treatment of the underlying cause. And now, because we have so much more in our armamentarium in the last few years, there's a significant number of medicines that have been shown to slow chronic kidney disease progression. These medicines are common medicines that you may already be on or have heard about for your hypertension or your diabetes, things like lisinopril, losartan, and then these new class of medicines called deflozins or SGLT2 inhibitors. Dapagliflozin is Forxiga, and pagliflozin is Jardiance, canagliflozin is Ivoplam. How can I keep my kidneys healthy as I sip a glass of water unintentionally? So heart health and kidney health are intimately related. Anything that you do to keep your heart healthy will also keep your kidney healthy. Controlling your blood sugar, controlling your blood pressure, key elements of maintaining good kidney health. Maintaining a healthy body weight in the same way that the cardiologists have made exercise famous for being heart healthy. It is just as good for keeping your kidneys healthy. Similarly, eating healthily, important both for the heart and the kidney, and getting regular exercise. There's something about exercise that not only helps the myocardium or the heart cells, it also helps the kidney cells. We have had well-established treatments to treat chronic kidney disease since the 1980s. You can see these papers from the 90s and the early 2000s that show that certain classes of blood pressure medicine slowed kidney disease progression and reduced protein levels in the urine. So for the purposes of the next few slides, it's important to just understand how these graphs are read. So on the bottom, you have time. Time starts at 0 and marches out to the right, same down here. And then whatever event they're trying to track in the study is graphed on the y-axis. So here you can see percentage with doubling of baseline creatinine. And remember, the higher the creatinine, the worse the kidney function. So generally, anything on these y-axis you don't want to get. You want to be in the lower percentage so that there are fewer of these bad events happening. So whenever you're looking at a study like this, if the placebo is running much higher than the study drug, that makes the study drug company, whoever is funding the study, very happy. Because that means that, say, captopril in this case, the group that was getting captopril has a significant number of fewer events than at the same time period the group that was getting placebo. Hopefully that is easy to follow. We talk about separation of lines. So if the lines ran together, that would tell us there was no difference in the percentage of events. The people on placebo had the same number of events as the people on the study drug. When the lines separate out so nicely like this, This tells us with quite a bit of confidence that captopril is preventing events that the placebo group is suffering from. And so since the mid-90s, we've known that medications like captopril, lisinopril, losartan, a whole class of medicines, is responsible for slowing down chronic kidney disease progression. And they've been in the armamentarium for 30 years. Unfortunately, they've been the only thing in the armamentarium for 30 years. We have not had a significant breakthrough in looking at these same kind of plots where we look at events between the study drug and placebo until recently. I'll get to that on the next slide, but an important issue, one of the things that my research focuses on is trying to apply what we know works at the bedside, because I want to draw your attention to this graph down here in the left bottom panel. This is showing for all the people who should be on the medicine that I just showed you, the ACE inhibitors or angiotensin receptor blockers over time, starting in 2001, moving to 2018. This is the percentage of folks for whom the drug is indicated. They're actually getting it. And this is why I am so interested and passionate about what I and we, my teams, are doing, because we know the data are there, they are strong, these medications are inexpensive, they're commonly and easily available, but access to care and getting patients on the right medications, you can see we only get it right about half of the time, and we've known about this for 30 years. So I won't divert too much of an aside to that, but I think it's important to understand we've had a great therapy for slowing chronic kidney disease for a long time. We still haven't mastered making sure that we implement what we know works, that we deliver to our patients what we have known has worked for so many years. And then the stage is set for this first important trial that came along in 2019 called Credence. Credence was the first medication, canagliflozin, of the class of medications that have revolutionized how we in nephrology and cardiology and pulmonology treat chronic kidney disease. These were medicines originally, I think, came to market in 2012, and they were prescribed to lower blood sugars, but it turns out they don't actually lower blood sugar all that much. And so the pharmaceutical companies began noticing these other important outcomes. And now these drugs have shifted from being primarily endocrine, diabetic type medications to being primary kidney and heart medications. And this is the reason why. So I'll show you just a couple graphs over the next slides. This is the Credence trial, the first trial that came out looking at how does this drug affect kidney disease in patients with diabetes. You can see that in the canagliflozin group versus the placebo, this is a graph you want to have low. You want the urine albumin ratio to be low. Remember, I mentioned that the higher the urine albumin goes, the more more untoward outcomes, heart attacks, strokes, those kind of things that happen. So this drug both lowered the albumin in patients' urine, which is our focus in nephrology, one of our focuses. And then perhaps more significantly, it slowed the rate of chronic kidney disease decline. So on this graph, again, time starts at 0, marches out to the right. And then as you go down, this is loss of kidney function over time. So in patients who are on placebo, the yellow line, you can see that their kidney function just continued on a pretty steady rate of decline. What we are most interested in doing in nephrology is flattening that line. The flatter we get your progression line, the more time you have away from dialysis. And that's what the difference between these two endpoints is, way out here. So this was really revolutionary. This trial was stopped early, actually, because the investigators thought these outcomes are so good, it's not ethical for us to withhold this medication from a placebo group. And then it turns out another trial came out in 2020, another flozin, this is dapagliflozin or Farxiga. And you can see the graph looks the same. They noticed the same type of attenuation or flattening of the GFR slope here. And this is what I show patients in the office when I'm starting them on this medication. I say, you know, The idea is if you don't start this medicine, you're in the placebo group, and your kidney function will decline and become suffering. But the opportunity we have with starting this medication is that we bend this curve and give you more time. See, at this time point, 36 months, the placebo group has lower kidney function than the study drug, or the dapagliflozin group. And this is kind of the holy grail of nephrology. It's managing CKD well enough that we actually slow the rate of chronic kidney disease progression. And then a third study came along. This was just last year. And interestingly, this trial called DAPA-CKD was different from Credence because not only did patients have kidney disease and protein in the urine, but this was all, this patients did not have to have diabetes. So in the Credence trial, you had to be diabetic. But then DAPA-CKD came along and said, look, the effect is the same for any patient with CKD and protein in the urine. You don't have to be diabetic. So then we thought, well, maybe it's more applicable to everybody. And then dapagliflozin or kidney came along, and it turns out you can see the shape of the curves look exactly the same. So all three of these drugs in this class called SGLT2 inhibitors have the same positive effect, slowing the rate of kidney disease, chronic kidney disease progression. And I just show you this to drive the point home further. This is again from the DAPA-CKD trial. Not only do these drugs slow kidney disease progression, but when you look at, again, remember the chart I showed a few slides ago, study drug versus placebo. And again, we're back to bad outcomes here on these graphs. So renal specific composite, death from cardiovascular cause, death from any cause. These are events you don't want to have. And in every instance, the blue line, dapagliflozin group, does significantly better. So not only is it slowing chronic kidney disease decline, it's preventing heart attacks, preventing strokes, and preventing death, which was, again, all three of these trials were stopped early because of the ethics group saying that the outcomes are too good. We can't ethically withhold this drug from the placebo. That was the end of the some of the chronic kidney disease stuff. I know we have a few minutes left. Excuse me. I just want to highlight something that came out this morning. So for any of you who don't get to check the New York Times every day, this was in my New York Times email this morning. Surgeons at Brigham Mass General, I should be specific, surgeons at Mass General transplanted a patient last weekend who had end-stage renal disease but was too sick to get a kidney transplant, to be on transplant, the deceased on the transplant list. They implanted a pig kidney, and they reported on it today in the New York Times that he's up and walking, making urine, doing well. This is the first time so-called xenotransplant. Xenotransplant is when you take one species of human and another. This is the first time that the pig kidney was, or any non-human kidney, as far as I know, was transplanted to a human. And amazingly, the kidney is producing urine. And so far, it's early stages. But I thought this was exciting news and timely for the talk tonight. A couple of common questions that I've gotten from patients and over the years of giving similar talks to this one. If I have CKD, will I need dialysis? The answer is no. As you remember from the kidneys by the numbers charts, the number of patients who have CKD is much, much higher than the patients who have end-stage renal disease. So it's certainly not a foregone conclusion. What is a kidney-friendly diet? I only touch on this because there's a lot out there on the internet you'll read about kidney diet this or kidney diet that. Most of us think that balancing your diet to whatever your other diseases, such as diabetes or cardiovascular disease, is probably the majority of the dietary intervention you need to make. One of the only things that I usually tell patients is to be mindful of how much sodium they take, how much salt they eat. There are data that suggest that high sodium diets can make kidney function worse. Most of us think through higher raising the blood pressure. But there's a lot that you'll read out there about potassium, phosphorus, protein levels. Those are very specific to what kidney disease stage you have or where you are on the spectrum. So I say that just because not every kidney patient is to adhere to the same diet. Although most patients will do well if they monitor their sodium intake, moderate their sodium intake. Does drinking more water help? I addressed this earlier. It's not about how much water you drink. It's about how much water is right for you. So if your urine is light, relatively clear, you're hydrated. If your urine is dark, you need to drink more. That's the general advice I give to my patients. Is there a supplement that I can take? Generally not. I say this because, again, many patients will read online about kidney boost or kidney health this or kidney repair that. There is not a supplement that's been shown to slow progression significantly. And so I always advise patients to approach these cautiously. What should I avoid? There's a lot of things that you'll read about that should be avoided, CT contrasts, etc., certain medications, PPIs for reflux disease. The only one I mention to patients that has a pretty strong correlation is not to take too much non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, Motrin, Advil. It's not that you can't take them at all. It's just that if you take them regularly for months or even years at a time, there are association data that show you put yourself at risk for developing chronic kidney disease. And how can I take charge of my chronic kidney disease? It's fairly simple, and it has mostly to do with understanding your diagnosis so that you can engage in your health with your providers. Know your numbers. What's my GFR range? What's my free apnea range? Do your best to keep your heart healthy and leave the medicines to your providers, the medicines that we focused on to slow progression. I just leave this last slide to drive home the point that kidney health is like heart health. It's not any one thing that will get you across the finish line. It's a combination of you doing things to keep yourself healthy, eating well, doing your best to exercise, maintaining healthy body weight, maintaining healthy heart function, and then augmenting that with the benefit of all the new medicines and therapies that we have out there to help protect, preserve the kidney function that you have and manage the chronic kidney disease that you have so that hopefully you will never progress to the later, more advanced stages. With that, I'll say thank you very much. James, I'll hand it back to you for some questions. Thanks very much for your attention.
Thank you, Dr. Brady. Yeah, a lot of questions came in, and actually the list of common questions that you had on the screen, and you anticipated a lot of the questions. So thank you. Yeah, and so this one that came in was about the news today for the kidney transplant from a pig to human. So the question is, how soon will this become an option for real patients?
I should have prepared for that question when I put the slide up. What I tell patients when I get that question, what is actually closer to prime time, I would say, is what's called an artificial kidney, which is a very small device that they're trying to essentially make like a wearable dialysis machine. This xenotransplant stuff, I think, is years and years away from prime time. All of the xenotransplants that you've heard about or read about have all been research funded. They're not kind of like clinics that are open for people to go in and get this stuff done. This is people who are too sick for what is clinically available. So then they're rather than the alternative, they're trying something that is only really at the level of research right now. So I usually tell my patients years and many years, I would say.
Okay, thank you. And this one comes from a wine drinker. If I drink 2 glasses of wine a day, is it going to be bad for my kidney health?
This is a delicate question, though I get it a lot. In general, the kidneys are not the liver. Wine and alcohol is mostly water. So they view those kind of things like they view water. That is not reason to go, overindulge. But in general, there are no ill side effects to the kidney of having a moderate amount of kind of recommended alcohol intake. And I would say, 2 glasses of wine for most people probably falls under that category.
Got it, thanks. And this next question comes from a caregiver of an older person with a chronic kidney failure. And the person asks, what should I pay attention to? If I'm the caretaker?
Yeah, that's a good question. A lot of it relates to the stage where on the spectrum the patient is, because unfortunately, until the very, very end, when patients are nearing the point where they need dialysis, there really aren't any symptoms that you should look for. And even at the end, the symptoms are very nonspecific. There's things like fatigue, nausea, vomiting, weight loss, confusion, that in any one of those it could pop up. It may not be kidney related, but when we put all those symptoms in the right context, we can attribute those symptoms to end-stage kidney disease. In general, what I would say to caretakers is making sure that medications are being adhered to is probably the most important thing to do. And if you have a way to kind of, keep track of blood pressure and that kind of thing, those are arguably more important than worrying about symptoms, because you just won't get symptoms till much later in the game.
Okay. Next question is, my doctor tells me that I have mild kidney disease, but he didn't put me on any diet or treatment. Does this sound right?
It could be right. So many patients will show up to their first visit with me and they won't have heard the term chronic kidney disease. And many of the things that I'm saying, the phrases that I'm using, terminology I'm using, are new to them. Most primary care doctors are actively treating, they're aware of your chronic kidney disease, but they may not bring it up during the visit because there are other things that actually cause you symptoms like back pain, like chest pain, like shortness of breath, that they have to focus their visit on, even though they know in the background they have to be aggressive with this person's blood pressure management, they have to be aggressive with their blood glucose lowering because they have chronic kidney disease. So I think what I would empower patients to do is again, go back to your numbers, see where your average GFRs have been over time, get a sense of where that puts you on the spectrum at stage, and then just go in and have a conversation with your provider about it, and go from there. But it could very well be the right thing that they're doing. They may just not have highlighted that the lisinopril that you're on for blood pressure is actually both for blood pressure and kidney protection.
Okay. We have a couple of minutes left. So the next question is, if I'm between age 60 to 65, what kind of tests should I ask my doctor to give me?
Only two, really. So most primary care doctors every year will get a metabolic panel of some kind, basic metabolic panel, comprehensive metabolic panel, renal panel. That will have your creatinine and GFR. And we probably have a lot of those historically if you go back and look. The one that I would add is just if you have diabetes or you have hypertension or you have significant obesity, I would ask your primary care doctor to add the urine test, the urinalysis or urine creatinine ratio, urine albumin to creatinine ratio, I should say. You can kind of, in common terminology, say, is there a way we can check if there's any protein in my urine if you haven't had that kind of testing before? But those are it. Those are the blood tests for creatinine and GFR and the urine tests for albumin and protein.
Great. We are right at 8 o'clock. So thank you, Dr. Brady, for sharing all your great information. And thank you to our audience for joining us for the great questions that you sent in. Thank you and good night.
Thanks very much. Take care.
Bye-bye.